Ooh, see, I upgraded. So now, there we go. Oops, what screen do you see now or not?
The lesson plan.
The lesson plan, okay, cool.
It says concepts.
Yes, thank you, because it's not highlighted on mine. Okay. And so then what we're looking at specifically, like we just talked about, were the fetal and genetic congenital defects. We are going to focus on the cleft lip and palate, the TE fistula, and we're going to also talk about neonatal abstinence withdrawal syndrome. We talked about Down syndrome a couple of weeks ago in week 2. And then to keep in mind that for 6A, I think Mrs. Thorpe might have talked to you about newborn adaptations, right? Like when babies are born, things that happen, things that you can expect. And then as we progress, we're going to, in future weeks, talk about the pyloric stenosis, cardiac, and neural tube and ortho defects. So we will get to those. Sorry, trying to keep my chat open at the same time. Oh, okay. Let's see. And so then here's your learning outcomes. So this is the reading. So again, this was really the specific reading. I know a student had a question on if the readings had changed, and I don't think so necessarily. I didn't specifically add the readings because we were going to cover it in lecture, and then if you wanted to go back and do the readings, you can. I'm pretty sure there's not something like this on the midterm because I just tested it on the quiz for those topics. But after class, we're going to do a little review if people want to stay after. I said I would stay if people had questions. And then you've got the case study and the care map. So let's go through and look at, this is how you do the tracheoesophageal fistula repair. Let's go look at, here's what I wanted to look at, is the cleft lip and palate PowerPoint. I don't know if people have gone through that yet, but you've got the video here on the fistula repair. This would be guidelines, care guidelines. But if we look at the at cleft lip and palate, so basically, if you're thinking in terms, this is why it comes under nutrition, right? Because if there's a hole in the roof of the mouth, if there's a hole in the lip, how does that affect nutrition?
Help them to eat.
Right. That's one of the main things is the eating, right? It can be very difficult to eat. And so that's what we're looking at this top part. When you think about nutrition and elimination, we're talking about the part where the mouth is. And so you have two distinct defects that can occur, or they can occur together. So you can have a cleft lip just by itself. You can have a cleft palate just by itself, or you can have a cleft lip and palate that occur together. You can have what they call a unilateral, which is one side of the lip or the palate that that has the cleft, or you can have what's called bilateral. So you have, but like both nares are affected and both sides of the hard and soft palate are affected. And so what is another problem that could potentially happen besides nutrition when you have openings like this? What other concept would we be worried about?
Infection?
Infection, yes. I was
Oh.
one up a little bit higher. Huh?
Maybe aspiration.
Aspiration. Right, so we have nutrition, you have infection, and then like aspiration, respiration, because the aspiration could have problems with respiration as well as infection, right? So that's why we have to be careful and be aware. And so different causes. Oh, it does say maternal smoking. Okay, multifactorial. Most of the ones I've seen are genetic. And then we added folic acid. We didn't used to have folic acid in the prenatal vitamins. Like everybody gets prenatal vitamins, even postpartum now, right? Like everybody gets Colace and prenatal vitamins. And then the prenatal vitamins have the folic acid in them. And so sometimes you can detect these on an ultrasound, but not always. And so oftentimes the first time you are aware of this and or the parent is aware of this is when the baby is born. So how does that feel for you as the nurse present and, excuse me, as well as the family that's there? How might the family feel, the mom, the support person, and how might you feel as the nurse once the baby's delivered?
Surprise?
Yeah, surprised.
She might blame herself.
Yes.
As a nurse, you may feel a bit of anxiety having to speak to the mother or explain things to the mother, especially if she's in an emotional state after realizing the situation.
Exactly. And so that's why we had some of those questions in the quiz, right? Because oftentimes that is true. Like the doctor's not expecting it, you're not expecting it, but you as the nurse kind of have to go into, I don't want to say emergency mode, but you might have to suction, you might have to do some things that you weren't expecting that you were going to have to do. And the mother might be the same thing. With a cleft palate, you can't necessarily, you can't see it on the outside. And so you oftentimes don't realize it until the baby is suctioned, and you can't suction anything because there's no seal. With a cleft lip, it is very noticeable, especially with the bilateral where it's both sides. And I mean, I don't want to say, we always want the cute baby, but I mean, it's a shock. It's really shocking. The doctor would, hopefully the doctor will explain it, because what's probably going to happen is everybody in the room is just going to go, right? Hopefully not audibly and too much. I actually ended up with, I have 2 of 3 OSHIT babies because the second one had a cleft palate, which we were not expecting. And they went to go suction. And then they were like, oh crap, cleft palate. I already could tell there was something wrong by the cry. It was a very airy cry, and I knew something was wrong. But they said, well, basically what the doctor explained it right then. Well, it looks like the baby has a cleft palate, which is an opening in the palate. And so they explained it at that point. So the doctor is in the room with you, right, when the baby's born. So it would be the doctor's responsibility to explain that. And then the nurse can, oh gosh, I'm sorry, Kelly. Did they notice it right away? Do you know?
Yeah, so later on, my partner told me that, he had kind of overheard one of the nurses saying, oh, look at her feet, under her breath or whatever, to another nurse.
Mhm.
But yeah, I mean, I didn't even, like, she's my first kid. And so I
Mhm.
didn't even realize anything was wrong. I was like, oh, kind of turned in a little bit or whatever. And I mean, it wasn't like it wasn't like an extreme case, but it was noticeable. But I was like,
right.
oh, she was just cramped in my belly for however
Mhm.
long, maybe that's
Right.
a little stretch out or whatever. It didn't even like register to me that something was, wrong.
Mhm.
And so, yeah, I don't know. It was just really interesting. So then like the doctor came in like a couple hours later and was like, oh, hey, this is an issue and we'll have to have it treated and whatever. And I was like completely blindsided.
Mhm. How, if you remember, if I can ask, like how, this is kind of a crass way to say it, but like how caring do you feel the doctor was when he or she came in to talk to you about this?
So it was very caring, but I think
Good.
that was because the doctor that came in to talk to me was my OB. Like he wasn't there for the birth, but he was kind of
Oh.
like basically coming in and checking on us because he was at the hospital that day. It was whatever. I was induced the day before and whatever. And so yeah, I mean, he was like, and also he was born with clubfoot. And so he was able
Oh.
to Yeah. So it was, I don't know, it's just, I mean, my whole birthing experience was, I'll tell you guys the whole story sometime, but it was not pleasant for me, you know, it was
Right.
a little bit traumatic, etc. And so just all these things that I'm learning in nursing school, I'm like, oh, that was supposed to happen. You know?
Yeah, a lot
And
of
I'm like,
it.
okay, I'm definitely, you know, now I can take these into account as a nurse and treat my
Mhm.
patients differently than I was treated. But yeah, so anyways, it's just interesting. Don't leave parents hanging, guys.
Right. And Vanessa, to your point, sometimes I think we as nurses find the defect before the physician, depending, because let's see, for example, if it's a C-section, I know at CHOMP, the pediatricians are right there. They see the baby like immediately. And so they're doing their newborn assessment. I'm not sure at Natividad or SVMH that they're right there. They do the so when the newborn assessment is done. Now, a cleft lip, everybody's going to see right away, right? There are some defects that gastroschisis, omphalocele, you're probably going to see those on ultrasound and be expecting them, the GI defects. But I would, sometimes the parent will point it out and say, oh gosh, it looks, the foot looks funny in a club foot type of thing. The foot looks funny, or maybe we didn't realize there was a cleft palate, and the mom's like, yeah, I was looking in their mouth and it looks like there's a hole, you know, in the mouth or something. So it might, what I might say is, oh, you know, let me take a look, or let me see, oh, I mean, you're right. You have to validate, you know, that there's, you know, I do see the hole there. I do see the foot does look like it might be turned a little. You know, let the doctor know and have the doctor come take a look. Now, my thing is, if it's something that my child has had, sometimes I'll say, oh, you know, gosh, there is a hole that does look like something that we call a cleft palate. I'm not the doctor. Let the doctor know. Let me show you how to hold the baby appropriately. You know, maybe something like that. And then let the doctor know. Because a lot of times it is us as the nurse that's calling the, hey, by the way, did you notice? Which puts us in a bad spot, but I wouldn't go into all like the, you know, medical and all that kind of stuff. So we kind of talked about that already. So here's your cleft lip. And here's some, sorry, these are, I'm going to show you pictures if you haven't seen them yet. So, so that's a unilateral cleft. And that one's a bilateral cleft. You see they have a feeding tube. Most often they'll have a feeding tube and you'll be doing gavage feedings. Cleft palate can be hard and soft, or hard or soft. Sometimes it can be just a little tiny hole, and sometimes it's everything's wide open. And that's why we have you check, right? The palate, we say check the palate. Sometimes if it's a small hole, you'll see milk, they say formula milk, something coming out of the nose because of the opening, goes from the palate to the nasal passage. And then surgical correction, the cleft lip generally happens pretty early, the first couple months, depending on how the child is. You can always do more plastic surgeries later on. It immediately helps with the sucking, the appearance, sometimes the bonding. Cleft palate, they generally wait a little bit longer. This is actually a picture of they call it an obturator. It's kind of hard to see, but it's almost like remember retainers? We had retainers when you were a kid, you know, and it kind of covered over your palate. It's kind of the same thing. And I've seen some like, can you breastfeed with cleft lip and palate? You can, it's difficult. You need a lactation consultant, but it can be done most of the time, but you still probably have to supplement. It's a lot of work. So if you're thinking about cleft palate, remember we talked about with the cleft lip as well, infection, right? Who said infection? Hugo said infection, right? So with the palate, everything's connected, right? The ears, the throat, the nose, it's all connected. So upper respiratory infections, ear infections, sometimes you can have hearing loss because there's so much fluid. A lot of times they'll do the ear tubes, what they call a laryngotomy. And so my son had those till he was probably 10 or 12. And there can also be speech difficulties, teeth, the gums, overbites, underbites, any kind of dental problems. So there can be with cleft palate, I think, a little more long reaching complications to keep in mind. Cleft lip also. But again, a lot of times that's just closure of the lip or matching the nose and the upper lip. And so you can do some plastic surgeries. You can do, sometimes they also have to do what's called a pharyngoplasty, where they have to open it up a little bit more in the back of the throat because everything's kind of condensed together. So it's difficult to breathe. And the other thing with cleft lip and cleft palate, when you talk about interdisciplinary teams, there's like a craniofacial, these all fall under craniofacial anomalies. You have a craniofacial team that has RNs, MDs, plastic surgeons, craniofacial people. You have speech therapists, PT, OT, case managers. Like you have everybody on the team, which is really kind of cool. The problem becomes you go from person to person to like you're there all day. When you go, it's a long day for the family because you go person to person to person, but it's nice because I think you feel heard, and you feel part of the process, which is nice. The surgery generally done before 12 months, depends again on the size of the child, how big of a defect. What they're trying to look for is how stretchable because they have to bring the palate together, right? There's this opening and they have to bring it together. So they have to make sure that the palate is stretchable enough to pull over. It helps a lot with the speech pattern. We were actually they wanted us to be in a study where they weren't going to do palate closure until the child was 2 years old. I didn't particularly care for that because I'm like, well, what about eating? What about speech? What are we, And so we actually left that hospital and went to a whole new craniofacial team. You have that option. If you don't like the care, then you can go someplace else. And so again, for cleft palate, cleft lip, again, you guys hit it right on the nose, right? The sucking, aspiration, the growing with the weight, know their baseline weight, know what they look like on the growth curve, their individual growth curve. Yes, be aware of the bonding, right? We talk a lot about that. There are many support groups, coping groups. The craniofacial team has generally support groups that they run, and making sure that the parent is able to feed the infant. And so when you're feeding with cleft lip and palate, there are specific bottles. I think I might have pictures. And even though we say, hold them this way, do it this way, and that's what you would be tested on per se, every child, every parent is individual. So you kind of have to keep that in mind and do what works for everybody. So, and we're gonna go into the case study here in a second. You can breastfeed. A lot of times you're gonna have to pump and feed in a special bottle. These are examples of different bottles. There's the squeezable Mead Johnson, the Haberman. The Haberman is often used, it's a flow control, you turn it. It's often used for preemie babies as well. That tells you about that. And then there's all these different other kinds. There's different shaped nipples. The Ross nipple is just like this little tube kind of thing. People can use nipple like droppers. You can cross cut the nipple bigger. There's a lot of different ways to do that. This is actually what I used to feed my son. Yes, that is a Coca-Cola bottle. It is a glass Coca-Cola bottle. Question? Is there a question?
No, just shocked.
Yeah, and so the nipple is actually what they call a lamb's nipple. When you see them feed bottles to lambs, to sheep, right? You got this. My mom got this from a feed store, and so it had a hole in it, which was great because my son couldn't suck, but he could bite. He could like chomp, compress, and so that's what we did. And then we just eventually got it because he couldn't take a wide bottle. We needed the narrow neck. And that's what we got. And you guys can read through all
Did you
of
guys figure that out on your own, or was that like a suggestion from your doctor? Was
Not
that-
from the doctor. It was actually from some of the support groups that I looked up
Cool.
and doing research on my own. Paste feeding, all that kind of stuff. So then pre-op, you know, you want the high formulas, we're probably high calorie formulas. A lot of time, like my son was, we did NG tube feedings for a long time. And then I worked really hard to get him to be able to bottle feed. We tried so many different combinations of different bottles, different nipples, till we found something that worked. The glass was better because it wasn't like it held the pressure better. So here's some things to know specifically for cleft lip. So this is called a Logan bow, and it actually, it helps it's like this little thing that comes out in front of the face so the baby can't really hopefully touch the incision line. It also holds the incision line, the tension, so that if the baby's crying, or it doesn't put as much pressure. And then this baby has the little wrist restraints on. Oftentimes you'll see ones that are called no-nos that actually are their elbow restraints. And so you need to release those every so often to make sure they have range of motion. 1 arm at a time, every 2 hours for 15 minutes. There you go. So you can rinse, you can put the topical antibiotic on. You don't want to put things in the mouth initially because you don't want to mess up the surgery that just took place. You're not going to place them prone on their stomach. You can put them up in the car seat, not all the time. This is just, you know, you wouldn't normally do that. And you got the Logan bow, and yay, look at that. Woohoo. Little crooked, but better than all open. And there's all kinds of groups out there, and you can make donations and all kinds of things like that. It's just absolutely amazing. Here's the no-nos, right, that cover up the elbows. If they're in the hospital, every 2 hours for 15 minutes. And then for the palate, not obviously, but no straws. No, I mean, you have this incision right on the inside of their mouth, no straws, no pacifiers, nothing in the mouth, no metal spoons. You can start with soft foods, and you're going to want to rinse. You're not going to brush any teeth. And one of the interesting things, just, I don't know if it's cool or not, but I thought it was cool, is that, so I had gotten him to be able to take a bottle. We had rigged up another special kind of bottle that he took from 6 to 9 months. He had his repair at 9 months. And after that, he went straight to the sippy cup. We got rid of the bottles. We didn't have to ever go back to bottles with him. We just went to cups after that, which was kind of cool. And so here's what you need to know, right? Cleft lip pre-post-op teaching, effects on the nutrition, the cleft palate pre and post-op teaching, like the same thing, the safety, that kind of stuff. So that's what you need to know. And then Operation Smile, that's one of those. UCSF Benioff has a craniofacial team there. And those are some references for you. This link here will take you to other bottles, cups that you can use. So questions on cleft lip, palate, nutrition, breast, you know, the risks, the safety, all that kind of stuff.
I
Nothing?
have a question, Ms. Solinger.
Yeah.
So after the infant has gone through the surgeries, what's like their expected outcome? Like, are they back to, like, after a certain amount of time, are they back to being able to eat normally, or is there always going to be?
Mm-hmm.
Oh, okay.
So it's I guess if you're thinking post-op, right? You're thinking once
Yeah.
the incision is healed,
Yes.
right? And then things are, I don't want to say fine, but fine. They're not, again, not like a lot of hard foods. You're going to start with soft foods, which they would be on anyway. They can do some table foods. It depends on how many surgeries, because sometimes they're going to have multiple surgeries, either to close or to build out the palate a little bit more. You lose your uvula
Oh, wow.
times. And so actually, when my son had his tonsils taken out, he lost his beautifully newly formed uvula that they had given him when they did the plastics, when they did the original cleft repair, because it wouldn't necessarily be a bifid uvula, but it was half the uvula was on one side and half was on the other side. And so when they put it together, he had a nice little uvula. When they took his tonsils out, everything stretched and he lost his uvula. But yeah, things will go back. They can eat. You can put things in the mouth. Usually after like a 6-week, it could be a little less depending. Once the physician says it's okay, then you can start progressing.
Okay. Okay. Thank you.
Okay. So what about in the case study? What did you guys think of the? Let me find it if I can find it. What did you guys think of the? There it is. Of the case study, what questions, what ideas did you, sorry, shift my position here. Let's take a look at that. And I think almost everybody has it turned in, so remember to get that turned in. Right, so you had to look it up on the growth chart, which you've had to do. Different things that you want to know in the history. Excuse me, and I'll post the answers later today so that you can review those. And so pre-op teaching, do you guys feel like you have a better understanding, or you had an understanding of what the pre-op teaching?
Yeah, I do.
Okay.
I did.
Okay. Fluid maintenance requirements, right? How are you going to make sure that you know that they have adequate hydration status? So she's got they had repair, and then they're going to come back in 6 months later for the palate repair. And then there's the palate repair. So it's asking you for interventions. So what do you need to know from the case study? Like what's 1 or 2 takeaways that you got from running through the case study? Key points? Things you might get asked on a test in a short answer format?
I have
Well-
a better understanding now of, ideas of what you can do to keep them from touching their mouth and how to clean the area appropriately after doing the.
So that would be post-op care.
Mhm.
Okay.
Yeah, I wasn't aware that all the different types of services that are needed for a cleft lip repair. I mean, I knew some of them, but I was surprised to see so many different services that are needed.
Yeah.
For just one birth defect.
Yeah, it's kind of amazing. What other like key points?
For me, I think one of the most helpful question was asking the daily fluid maintenance requirements, because it kind of brought back to like when we took Safe Medicate, we had to do the calculations for the total fluid maintenance requirements, and just know, I remember I struggled a lot with that. And so I just had to go back to my notes and then like kind of refresh my memory on that, because I feel like, it was mentioned on the focused area.
It
Maybe it's there.
was. Yes, it was. And I believe it sort of focused you into which of those 3 categories you should probably know on the focus areas. Didn't it? Yes.
Yeah, it had it for over 20
Okay.
kilos.
Ah, good thing to know. Okay. Anything else from the case study?
Mrs. Soldier,
Yes.
can I confirm that light, gentle suction with the bulb syringe is okay in these patients?
Which, excuse me, the cleft lip or the cleft palate?
Either one.
Yeah, you're with a bulb syringe, you would be better because you can place it more, and it's not like a yank hour that is that big long kind of tube thing. Because if you have to suction, you have to suction, and I would use a bulb syringe if that was the only thing that I had.
Okay, thank you.
Mm-hmm.
Mrs. S, I need a little
Yes.
bit of clarification about cleaning the site. Because on ATI, they say to use water or diluted hydrogen peroxide. And then in your PowerPoint, I see normal saline to clean the water. So I just
For
want to make
for the lip.
yes, to clean the
Yes.
site. Yeah.
So it's kind of like, I try to think of it as, we used to use hydrogen, we used to use alcohol wipes for umbilical cords, right? We used to use, which we haven't done yet, trait care, we would do the half strength hydrogen peroxide. Can you use half strength hydrogen peroxide? You can, but it can also break down the skin more than we want. And so that's why we want to try and use the dab it with water or use soap and water. As opposed to the hydrogen peroxide. Again, this is where sometimes I disagree a little bit with ATI. I think they're a little bit behind on some of that stuff. Would it be wrong? Not necessarily. Is it best practice? Probably not. That'd be a good PICO question. You know, to which is better, soap and water or half strength hydrogen peroxide. That's not something specific that you'd probably need to know. If that
Yeah,
helps.
we don't, yeah, that help, but you know, I just want to make sure because we can like just like come across of kind of those questions anywhere where they can ask, you know, where we can have both of them on like.
Oh, I see you're saying, when you have them both
Yeah.
as a choice.
Yeah.
Right.
So the better
Yeah.
one will be soapy water or saline. Okay. Thank you.
I have a question, Ms. Ollinger,
Yes.
about number 4, the laboratory tests. I wasn't really able to find that in the reading. So I just Googled what I could, but is that somewhere and I'm just missing it or?
So basically it would be things that you would be looking for in pre-op labs, pretty much pre-op labs.
Okay, in general.
In general, there's not really anything. And again, I'll post the answer key. But we're not going to need ABGs. We're not a stool sample for fat content. That's asking something else. I mean, a CBC I think would be good. A Chem 7, you know, maybe a urinalysis. I mean, I'd want to know their fluid and electrolyte status. Is what I'd be looking for.
Okay.
But I don't know why I would need arterial blood gases per se, and definitely not a stool sample.
Okay, so it's just like, there's not a specific one for this then. It's just
No.
a general pre-op. Okay. Sounds good.
We were trying to combine kind of some of the pre-post-op stuff that like Dr. Whitmore has given you, and then putting it in terms of now cleft lip, cleft palate, right? To kind of layer it, if that makes sense. And then what other, true false, case study, progress, right? We did that, let's see. Cleft palate, we're not going to use a straw. You're going to use pain medication. We're not going to use the, you know, the Yankauer, that's the long plastic kind of one, hard plastic one. Check I's and O's, check I's and O's. There you go. So were there any other questions on the cleft lip and palate case study? It sounds like you guys learned some things from it. Hopefully that was helpful. And some of that stuff was covered in the quiz. So that's good. Okay, that was that. Let's go back. All right. And then I want to cover, we're still good on time. Let's keep going to, so newborn screening, the newborn screening process. What can you guys tell me? What have you guys seen? Probably not on MedSurg, but in OB, what are you seeing with the newborn screening? Like, how does that happen?
Basically 24 hours after birth. And then they do, I think, a hearing screening, the early Robin screening.
Right.
And then the congenital
Yep.
diseases one, yeah.
Yeah, the heart disease one.
Heart disease one, yeah.
The CCHD. And so what we're going to focus on for this is specifically the metabolic screening. And we used to call it the PKU, which was for fetal ketonuria, but we've gone so far past just that test that we test for, that we like to call it the newborn metabolic screening. Excuse me. So I'm trying to, yeah. So for, in case you wanted to know, in California, that's what this link is for, right? You don't have to memorize the list. Just so you know, there's 57 different conditions that are screened for in that PKU. There's a form that you have to fill out. Some of you may have seen it. There's these little dots at the bottom. There's 6 of them now. There used to be 4, then there were 5. Now there's 6 of them. And the lab or the nurse, whoever's doing it, does the heel stick and then has to fill each circle with blood. You have to fill from the middle out. You have to keep it in the circle. It can't be messy. It's like fill in the dot kind of thing. That form has to be filled out exactly correctly, or it will be rejected and you will have to start all over again. They want it done once the baby, after 24 hours, because at least the baby has hopefully gotten some colostrum or formula or something, because they want to know how the body's metabolizing food, whether it's breast milk or formula or whatever. If it's a baby in the NICU, sometimes they will wait till day 2 or 3, not usually past day 3 of life, and do the testing at that point. A parent can decline, but like if they want to leave prior to the 24 hours, but they would have to go then to their pediatrician and have it done at the pediatrician's office. We advocate probably pretty heavily for the parent to have the newborn screen, and they tend to do it at the same time that they do the bilirubin. So it's only the one heel stick, hopefully. But this is just the list of different things that are tested. You have galactosemia, which we're going to do a little talking about, fetal ketonuria. If there are specific congenital heart diseases, there's certain enzymes that might show up. Cystic fibrosis, right? We now have cystic fibrosis in here. Hearing loss isn't part of the metabolic screening, but what else? Maple syrup urine disease, the medium chain acetylcholine, that's one we see a lot of these, propionic acidemia, sickle cell anemia, right? There's all these, look at all these things. Spinal muscular atrophy. I mean, there's just all these kinds of, I mean, who knew? Like, what did we do before this? Let's say, I don't know. And so that covers why it's needed. So if you're thinking in terms of galactosemia, what do you need to know? What do we need to know about galactosemia? Why would we want to know that a baby has that?
Is that the one where she needs a special formula? The baby?
Yeah, because why?
Because they can't digest the glucose, the galactose.
Yep.
And I think breast milk is contraindicated as well for that.
Yes, that is one of the few things where breast milk is contraindicated. That's John. Is that John? Yeah, John. Yep, trying to go off voices. And then let's see. We did that. And then what did you guys talk about hypothyroidism in adults or babies with Dr. Whitmore?
Yeah.
Because I know you did hyper.
Yeah, we kind of touched on that one too.
Okay, and so what did she talk about, or what do you remember about that? About hypothyroidism.
Everything is high.
Hypothyroidism.
I just think like decreased metabolic functions. So like lethargy, cold intolerance, weight gain, depression, things like that. And then they're
Mhm.
often given levothyroxine, which is a medication that'll help them produce more thyroid
Mhm.
hormones.
Correct. And then let's just do a quick little review here. Hyperthyroidism. What do you remember about hyperthyroidism?
That's where everything is high. Like they have a high, like a fast metabolism, and their heart rate's high. They have that exophthalmos or whatever with the
Mhm.
high blood.
Exophthalmos. Mhm.
And then with the hypothyroidism, they have to have medication for life, right?
For the hypothyroidism, if they do surgeries, like sometimes like if you have Graves' disease, there's certain medications, the propylthiouracil, the methimazole, some of those ones, but sometimes the Graves' disease will go away, and then you don't have to take the medications anymore. Hypothyroidism, generally, you're pretty much going to have to take that lifelong, but if your levels are good and can stay maintained, right? Because you're looking at what, T3, T4, TSH, right? Those the lab values, right? And you guys understand how those all relate to each other ish? Maybe not.
Not really.
Not really. Oh boy, let me do my best here. So so you start in the hypothalamus, which triggers your thyroid stimulating hormone. If your which is your TSH. So if your thyroid stimulating hormone is high, what does that mean? What are you trying to make up for? Right, your T3 and T4 are low. So the thyroid is like on overdrive. The lack of, thank you, David, the lack of the T3 and T4, right? So your TSH, your stimulating hormone is high. And then if it's lower, then you probably have too much. And so it's not working as hard. It doesn't have to work as hard. For babies, it's not like a baby could tell you, oh, by the way, I feel really tired. I mean, they're going to sleep maybe, but what you have in babies is something called congenital hypothyroidism. And so one of the things that the newborn screen could potentially pick up on is some of the enzymes or things that should be there that there's a lack of, and so that the baby has congenital hypothyroidism. So what you need to basically just understand is that the newborn screen can help to identify congenital hypothyroidism in babies. Okay, cool. Okay, and then so we're good on cleft lip and palate. We're good on the newborn metabolic screening. Are we good to move on to neonatal abstinence syndrome? Yes.
Yes.
I have a yes. Yes. Okay. Things are making sense ish a little bit more. Okay.
Yes.
We'll go with that. Okay. So neonatal abstinence syndrome, here's a little PowerPoint for that. So my students that have seen, has anybody at Natividad in the NICU seen a baby with neonatal abstinence syndrome?
No, but at another hospital I have.
Okay, because I know some of my students at SVMH have seen it. Can some?
I saw it in Natividad. This is Grace. Yes.
Oh, hi, Grace. So
Hi.
what did the baby look like, or what things, what characteristics did you see?
She looked pretty good, actually. I was surprised. It wasn't what I expected, but the main thing that this was a couple weeks back, but the main thing that stuck out to me was just the trying to limit as much like stimulation as possible. So just keeping her swaddled really nice and tight, and then just like kind of keeping it dark, quiet, like don't get her started kind of, because they said that there had been some days where they just were passing her from nurse to nurse because she just was like unconsolable. But when I was there, it wasn't so bad. They just said that those were their practices. And then I found the way, like she would suck like a lot for the feeding, but she would hardly get anything.
Mm-hmm.
So then they would have to just do the gavage feeding. And then she would get really tired out too, just because she would suck so much and then like hardly get much out of it. So, but as far as like physical appearance, she looked pretty good. Yeah, I can't think of much that I remember from her physical.
Were they, do you know what scores they were giving her? Were they using the Finnegan or another neonatal abstinence scoring?
Yeah, they were using the Finnegan. I can't remember the numbers, but I know that they were decreasing her morphine when I was there. One of the nurses actually accidentally underdosed her. And so during the conference with the other doctors, she brought it up and they said, yeah, that's fine. We'll just start decreasing her from this point forward because she was tolerating it. But yeah, so I can't remember. I might have it written down, but I can't remember the numbers.
That's okay. Because I can tell you what the numbers are. We're going to talk about that.
Okay.
What somebody from Salinas Valley, what was your experience?
Mine was similar to Grace's. This is Vanessa. The little boy that I was with, he did have like muscle rigidity, like increased muscle tone. So they did have him like really swaddled up. I remember he was like very inconsolable, a really weird high-pitched cry. He had diarrhea as well, but also his mom was, she was doing like a lot of drugs and drinking and smoking. So she was just like a whole combination of everything. He was really restless. The same as Grace, he was sucking a lot on the bottle, but wasn't getting much. I think the most he was able to get within those days was like 5 mLs each feeding.
Wow.
So they were doing gavage feedings for most of the time. Mom was uninvolved. Grandma was doing the care whenever she would go in between her work. But yeah, I mean, it was very difficult seeing him, and he was jaundiced also.
Yeah, it can be very difficult. There are babies that are, unfortunately much worse than what we're seeing or what we've seen so far. It's really kind of sad. Let's kind of go through some of the slides here. So these are some of the signs of the intrauterine drug exposure. So things you guys mentioned these, right? Prolonged high-pitched cry, very difficult to console. Yawning and sneezing can be some things. The jitteriness. Vanessa, you mentioned the muscle rigidity, restlessness, exaggerated Moro reflex. And what happens with the sucking is they're doing non-nutritive sucking. So if it's a nutritive suck, they're sucking and actually able to pull the formula from the bottle, the milk from the breast, which they're probably not going to be breastfeeding. But it's very difficult. It's more of that just sort of compression, but not really using the tongue and that type of thing. And that's why they only can take, they're sucking and sucking and sucking, but only taking 5 mLs, and it just exhausts them. But it's usually very difficult to keep them asleep. They don't sleep for very long. Normally, the babies will sleep like 3 to 4 hours, maybe. These babies barely sleep an hour at a time sometimes. And so then things that you'll see, this is relating to your care map that you did, right? We're breaking these signs and symptoms into concepts, right? And then we're going to come up with interventions. And so feeding, the sucking, the uncoordinated suck swallow, a lot of regurgitation, diarrhea. They tend to lose weight. They're sucking all the time. They're breathing really fast. They're jittery. They're using up a lot of their energy. And so they're not gaining a whole lot of weight, which is why we do the gavage feedings, right? And maybe even increase the calories of the formula. Sneezing, nasal stuffiness, tachypnea, oftentimes retractions. And then you can also see hypertension, sometimes fever. You don't normally see diaphoresis, which would be sweating in babies, but sometimes with these babies you do. Excoriation, meaning like redness of because they've been rubbing, they're just like constantly doing this. And so if it's on the sheets or their skin, if it's constant watery diarrhea, they're going to get a diaper rash. And the interesting thing is to note is that sometimes the baby doesn't have any signs and symptoms. But what we're going to find out is that based on the type of drug exposure, you might see signs sooner or later, depending on the type of drug and or combination of drugs. So this slide kind of shows you, the onset of symptoms. You don't have to know, alcohol is 3 to 12 hours or benzos are hours to weeks. There's not a question like that. The thing is to just understand that some things will show up sooner, some things will show up later, some things might not show up at all. But they'll do what kind of, so they'll do a drug screen on mom, right? And how do they get that drug screen for the mother? Is that blood or urine?
Urine?
I think my nurse mentioned they did a blood screen on the mom.
Yeah, you can do a urine as well. They'll try and do the blood because it's a little more accurate for the mom. And then for the baby, how do we do the drug screen?
Don't they put a bag like, through urine?
Yeah, you can either do a bag, or a lot of times we'll just use cotton balls. Because sometimes the bag gets messy, but you can do a bag, but a lot of times we'll do cotton balls because the urine will soak into the cotton balls, and then you can actually put the cotton balls in a syringe and squeeze them, and then you get the urine that'll come out the bottom for your sample. Just kind of cool. What's another way that you can do drug testing on the baby? What's actually more accurate method?
Stool sample.
Stool sample, right? You could actually do hair, but some babies don't have hair. So stool is a send out. And so the urine you'll get back that same day pretty quickly, actually. And then they'll often do another confirmation one where you have to get more urine and they'll test it again. The stool usually takes maybe 3 to 5 days to get back because it's a send out test, but it's more accurate for the length of time that the baby's been affected by the drugs. And then this will just get, and it also used to be thought that marijuana didn't really affect the baby. But if this particular link, and I think I have it in the resources too, that there are effects, it can affect the baby, which is good to know. I believe that's a video on assessing neonatal abstinence. This is what a modified Finnegan looks like. Again, we're taking all those same concepts, the sleep and rest and the respiratory and all those things, and scoring them. And then generally speaking, that's supportive care. So generally speaking, if the baby scores 8 or above, then we, oh yeah, good question, hold on. If the score is greater than 8, generally speaking, for 3 consecutive times, then the baby will probably be started on morphine. There are a couple other drugs that people could use, but morphine seems to be the one that I'm seeing the most still. You could do methadone, but I think for treatment of symptoms, the morphine is a little bit better. You're supposed to tell the mother what we are collecting the urine and stool for. Sure. I mean, yeah. Usually the mom, when the mom's using and she's told us, or we suspect, or we've had that conversation with her, we tell her we're going to test the baby for any drugs in their system as well. The problem comes when the mom says that she hasn't had anything, and then we get a blood test back and it's positive. And then we're like, oh, okay, well, but usually we will tell the parents because we want to, and usually we'll say, because we need to know so that if the baby becomes symptomatic, we can help them through the symptoms and the withdrawal. They're not, it's sort of a misnomer. They're not necessarily addicted in the sense, because addicted is like, I have to have more, and you go down that path. With the baby, it's more withdrawal, because once the withdrawal is done, and hopefully there's not any other systemic damage that's occurred, then the baby can move on, right? It's out of their system, and so they're withdrawing, and then we move on. So there's a couple of different ways to look at the name on that. But that is a touchy Yeah. Well, hopefully if you're collecting samples from the baby, you've had in report at some point if somebody has talked to them or not. You could potentially ask the physician if the physician has told them. These things usually happen ahead of time. Has anybody in L&D been in this situation? I don't know. I'm trying to think how they broach it in, because that's where it would start to happen. The questions would start to happen, because what's one of the questions in the intake?
Do you use any substances?
Do you need, yeah, and kind of go through the list of substances. So depending, you know, if they are using or they say they're using, then you can say, well, we need to, you know, for your safety, the baby's safety and health, we'll need to test your blood, and we'll need to check the baby as well to see if they're going to be affected.
So if mom says no, but for whatever reason, we think that may not be true, and we go to collect samples, and the mother asks, hey, why are you taking, you know, those samples? What are you testing for? Are we supposed to tell the mother?
That was exactly the situation that I had in a former hospital.
Yeah. And what happened?
We told them that the baby was displaying the signs that we were concerned of, you know, drug use, and that we needed to test the baby's urine to monitor for symptoms and complications. And we ended up bagging the baby, doing the, you know, urine bag.
And was the baby positive?
Yes.
And so then were you able to go back and talk to mom about that, or did they test mom?
Unfortunately, I had to leave.
Oh, got it.
My shift was up.
So are we allowed to refuse answering those questions?
I don't know if you're allowed to refuse. I mean,
this was a personal situation again with my situation. Is I was not on drugs because there was meconium in the amniotic fluid. They took that as a sign that I had possibly been on drugs and lied about it. And so when they came in to take samples, they were like, oh, we're going to take some samples of your, you know, baby's urine and stool. You need to make sure that you let us know when the baby has their first, you know, wet or dirty diaper, blah, blah, blah. And so when I let them know, they come to take the samples or whatever, I was like, hey, so what are you guys testing for? You know, and they flat out refused to tell me.
Oh, see, I don't.
Are they allowed to do that? I guess. Are we allowed to do that?
You are, well, let's see, the parent is of course able to ask. I try not to lie. It kind of depends. I don't want to say it's on the situation because sometimes
I was assuming that like probably they didn't want to tell me in case I was going to go ape shit on them. Right. Like,
right. I mean, that's one of the things. We also don't want them to leave AMA and take the baby with them necessarily, because Vanessa's point, it triggers a social services consult as well. And so I like the way that I think it was Shannon was saying that, you know, the baby's displaying some of these signs and symptoms, or, and again, I don't want to necessarily, I don't know if profile is the right word, but if somebody's been using methamphetamine, there are certain signs and symptoms that they may display that may lead us to believe that they are using, or especially if say somebody comes in and they've, you know, been smoking marijuana, they may come in and there may be an aroma, or their visitor or something may have an aroma. Not that we want to make that connection, but, you know, our goal is the safety of the child, of the baby, and you as not you, but the patient, right? The mom. And so I think if you generally put it in terms of that, is that for your safety to, you know, if you would need help, if you would need resources, we want to make sure the baby's safe. Are there things like hypoglycemia that it might be, you know, jittery, right? You know, because jittery can be a symptom. Sleepiness, you know, irritability. Sometimes I hear babies screaming down the hallway. I'm like, did we drug screen them? Because it's like a really irritable baby that won't calm down, that needs, but we haven't drug screened them for whatever reason. I don't know if they were or not. But then I have this other little baby here that's sleeping soundly and not showing signs and symptoms yet. We've drug screened them, and maybe they were positive for cannabinoids or something. you know, it's not an exact science, unfortunately.
Can you like generalize it? Just be like, oh, you know, your baby's experiencing some jitteriness. We want to just rule some things out. We're going to do a test or a few tests or something like that, instead of like saying we're drug testing your child.
Because even something like that would have shut me up. You know?
Yeah, just like some kind of explanation.
Yep. Yeah. And something that's not totally a lie, then I feel better about about that. You have to be creative sometimes.
I asked the NICU nurse, like, how did you know that this baby was going to be going through these withdrawal symptoms? And she said that it was very clear that the mom came in high, like she had just gotten high before she came to deliver. So then that kind of triggered, you know, there was no hiding that. So then they knew what to do from there.
Right.
That's all the info that I got, because I was curious
Right.
about that too.
Well, that's what I'm saying. Sometimes it's kind of obvious, and then other times it's not as obvious. And then even in some hospitals, it is a protocol. I want to say at SVMH, if they're 36 weeks or less, they automatically drug test, because sometimes the baby's premature because of drug use. And so in some hospitals, it's an automatic infant drug screen because it's a premature baby.
Miss Ellinger, Miss John, I think I had that same patient that Grace had. She also had the lowered ears and a cleft palate.
Oh,
yeah.
Interesting. Well, there you go. That just shoots my story right out the window there of it being genetic. There you go. That's too bad. And then I know for the one at SVMH, grandma was being involved. Yeah, the premature baby. That's right, Kenya. Yeah, it's just kind of sad. Let's keep going so we get through the end of this, because we only have a couple minutes left. And then, so let's look at your, when you were doing your, so supportive care, right? Which is going to lead into your care map. So with your, let's go back and look at the, let's see, make sure.
Ms. Solinger, can I ask a quick question?
Sure.
So say you have a 15-year-old woman or girl who's given birth to a baby. So given that the mother or the 15-year-old is still technically a minor, it is my understanding that she can make medical decisions for her baby, but is not allowed to make medical decisions for herself. It would have to be technically her parents that make the decisions for her, but her parents cannot make decisions for her child. Is that correct?
I believe so.
Okay.
That sounds correct. They could, because they're not the parent of their grandchild.
Right.
Yes.
Okay, thank you.
You're welcome. And so then here is this perfusion, this 2021 PowerPoint here. So this will also give you more information of the nutrition. I think I have, right? It's going to go over some of these. There are not any questions on imperforate ANS, gastroschisis, or omphalocele. I do have stories about gastroschisis because my first son was born with gastroschisis. But what you need to know, what you would need to know, like for the TEF, is what is a fistula? It's an abnormal passage, right? Atresia is an absence or a narrowing of something. So this is the one I wanted to show you for the TEF, is the different types. So you have the esophagus is on the, what is that, left-hand side, right? And then the trachea is on the right-hand side, and they're supposed to be separate things, one for breathing, one for eating, right? And so then it will show you the different types of connections or lack of connection that's made. And that's why you have issues that you will either notice mostly because of breathing problems. And then you have to work on the breathing problems, or you get air in the stomach or all kinds of other things. So I just wanted you to see, the choking, the coughing, the different symptoms that you'll have if there's TEF. For the atresia, if you can't pass the NG tube, an atresia would be a narrowing, like in the nose, if you can't pass the tube down. And then there's just before and after surgery type things. That's a video that you can watch. It talks about surgical repair. There's generally it's multiple surgeries that need to be done oftentimes to correct that. There's a picture we talked about imperforate anus a lot in skills and such. So I just threw that in there for you so you could see what it looks or doesn't look like. And then there's surgery, and then you have an anus now. And again, I've only seen one of those in my 30 years of nursing. This is a gastrostomy tube for a child. I don't have any questions on that in mind. This is a Mickey button, which is a more permanent one if you're gonna have long-term feedings, because you can actually take that extension tubing off. And so you've got the flattened part, which is nice. And again, I threw gastroschisis and omphalocele in. You will see those sometimes. The omphalocele protrudes into the umbilical cord. The gastroschisis is separate. The omphalocele tends to have more long range problems, whereas the gastroschisis, you can do closures and be done with it. There's different pictures. The one on the right is a silo. They actually put the intestines in like a bag that has normal saline, and then they kind of just float back on down into the stomach. Once it gets as they can get as most, then they'll close over it. And so what concepts are you worried about with these types of defects?
Risk of infection.
Risk of infection.
Restriction on the intestines.
Which would cause?
The tissue to die.
Right, so yes, so like a NEC, necrotizing enterocolitis, something like that. So yes, infection. Right, so these things that we're gonna talk about, you're gonna talk about pyloric stenosis later on down the line, but I just threw that in there so you had the information. Again, go by my study guide. Here's the picture of the intussusception, the current jelly-like stools. Here's your Hirschsprungs. So see how this is sort of the dead part of the intestine, right? And it's sort of where that is all swollen, but then the rest of the intestine is very skinny, and that's why you get the ribbon-like stools. Yeah, tissue integrity, exactly, right? So I just wanted you guys to see that. And again, because I oftentimes have seen or heard that there are questions on NCLEX about that. And then more guidelines, and I think interdisciplinary team, we've talked a lot about that today. For your concept map, what kind of, I know we have a couple, we're kind of over here, but what client problems did you come up with for the neonatal abstinence?
I was saying that we need to just educate the mother primarily on why breastfeeding would not be a great idea for her if she couldn't get her drug use under control.
Mm-hmm.
Because it seems like in the case study, like she kind of seemed like she was going to do it regardless.
Mm-hmm.
So I thought that could be a good, like, not a very obvious goal, but one to focus on, like really focus on her education.
Mm-hmm. Nice.
Oh, I have a question. I saw in the ATI book that it said that for methadone, it was not contraindicated for breastfeeding.
Mm-hmm.
So I was wondering, are there any restrictions if you have a patient that's exclusively taking methadone?
My understanding, because I had to look it up again, because I hadn't looked it up for a while, is that with the methadone, so little crosses over in the breast milk to the baby, but just enough to kind of keep some of the symptoms at bay, that the hospital stay for the infant who is breastfed to the mother on methadone, those hospital stays are shorter than babies who are exclusively formula fed, which I thought was interesting. So that's a PICO question, right? So they're apparently saying that if the mom is on methadone, that it's okay. And the methadone has a, Addie, wasn't this you? Somebody, we were looking this up, like what the lactation score was, right? The contraindications for the breastfeeding, and the methadone category is safer.
Correct. There was a L2.
Yeah, it was an L2. Thank you. Yeah, it was an L2. And so yes, the methadone is okay.
I think it's safer, but I think it still poses risk for the infant. I was reading, I think for one of my problems, I put that the patient is still at risk for SIDS because I was reading that, you know, if they test positive for methadone, I think it's cocaine or heroin, then they're still at high risk. So I think it might be safer, but it's still a risk for the baby.
Correct. Yep. So hopefully this helped you kind of put all that into perspective. I am happy to take a 5-minute bio break. So what is that, till 1 o'clock? And then I can be available to answer questions from the focus areas. While not giving out information, I will not record that. But for anybody that wants to stay around, we can do that for maybe, I don't know, no more than a half hour, if people want to do that.
Yes, please.
Or not? Yes, please. Okay, let me stop recording.